Welcome to The Explainer. Today, we're diving deep into Neisseria gonorrhoeae. Now, this isn't just any old bacterium. Think of it as a master of evolution, constantly changing to evade our immune systems and developing a scary level of resistance to antibiotics. It's a huge ongoing challenge for global health, and we're going to unpack why.
So here's our roadmap. We'll start with the disease itself, then get into how we diagnose it and the massive problem of resistance. After that, we'll cover treatments, prevention, the serious risks if it's left unchecked, and wrap up with a couple of real-world clinical cases.
All right, let's get right into it. The first thing to understand is what makes Neisseria gonorrhoeae so successful. It has these incredibly specialized ways of spreading and setting up shop in the human body, which makes it a real nightmare to control.
So what is this bug exactly? It's a gram-negative Diplococcus, and it's what we call an obligate human pathogen, meaning it literally can't survive without us. Its whole strategy starts with grabbing onto our mucosal cells, invading them, and then triggering this huge inflammatory response. That's what causes that classic telltale purulent discharge. Now, here's one of the biggest challenges, especially when it comes to women. Look at this chart. A full 60% of urogenital infections can be completely silent, no symptoms at all. This creates a huge hidden reservoir of the disease, with people spreading it without ever knowing they have it.
And you can really see the stark contrast here. In men, the symptoms are often loud and clear. Painful urination, discharge, it's hard to miss. But in women, even when there are symptoms, they can be really vague, like a change in discharge, and super easy to mistake for something else entirely, like a yeast infection.
And this bug is incredibly efficient. This number should really make you pause. 80%. That's the estimated transmission probability in a single high-risk sexual encounter for men who have sex with men. It just goes to show how effectively this pathogen can spread and why targeted prevention is so critical. Okay, so finding this pathogen is one thing, but today, the process of diagnosis is completely tangled up with the problem of antibiotic resistance. Honestly, it's the resistance that's now driving our entire approach to treatment.
Diagnosing this requires some careful lab work. You collect a sample, grow it on a special culture medium in a CO2-rich environment, and then confirm its identity. But look at that last step, susceptibility testing. This is absolutely essential now. It's not just about asking, is it gonorrhea? It's about asking what antibiotics will actually work against this specific strain.
And that brings us to the elephant in the room. The relentless global spread of antimicrobial resistance. I'm not exaggerating when I say that Gonorrhoeae has managed to develop resistance to nearly every single class of antibiotic we've used to treat it. And this chart tells a frightening story. Just look at what happened with ciprofloxacin, which used to be a go-to drug. Resistance rates have more than doubled in just a few years, skyrocketing to over 63% in many places. That has basically taken an entire class of antibiotics off the table. So, with our options getting narrower and narrower, what's left in the arsenal? Let's look at the current first-line defense that our public health agencies are recommending. Right now, the recommendation for uncomplicated cases is pretty clear-cut. A single 500 milligram shot of ceftriaxone, given intramuscularly. It's a powerful antibiotic that hits the bacteria hard and fast. For kids, the dose is based on their weight. And that last point is non-negotiable. A 7-day period of sexual abstinence is vital to make sure the infection is truly gone and to stop it from spreading further. And now for just a brief pause for a little microbiology humor. Why did the bacterium break up with the other bacterium? Because they had no chemistry. All right, let's get back to it. So, ceftriaxone can treat the person, but to control the epidemic, you have to think bigger. You have to focus on public health and on breaking every link in the chain of transmission. Partner notification is a huge part of this, but the strategy changes depending on the situation. If a patient has clear symptoms, you trace back their partners from the last couple of weeks. But what about all those asymptomatic cases we talked about? The trail is cold, so you have to cast a much wider net. We're talking all partners from the last 3 months.
So, prevention really has to be a multi-pronged attack. It starts with barrier methods like
consistent condom use. It also includes behavioral changes, like avoiding things that can damage sensitive tissues. Then there's proactive screening, especially for high-risk groups. And finally, gonorrhea is a notifiable disease, which means labs are required by law to report cases to public health authorities. That's how we track it on a large scale.
So what happens if an infection is missed, or it's asymptomatic and never gets treated? This is where things get really serious. The consequences can be severe and, in many cases, completely irreversible. You can see here the complications can be quite different. In men, it can lead to a painful condition called epididymitis. But in women, the infection can travel up into the reproductive tract and cause pelvic inflammatory disease, or PID. And in rare cases for either sex, the bacteria can get into the bloodstream and cause disseminated gonococcal infection, which is a systemic problem.
And let's just focus on PID for a moment, because this statistic is devastating. After repeated episodes of PID, a woman's risk of infertility can climb as high as 40%. 40! That's a life-changing outcome, and it drives home just how critical early diagnosis and treatment really are.
Okay, let's bring all this together now. We're going to walk through a couple of quick clinical scenarios to see how all these concepts actually apply in a real-world setting.
So first up, a 28-year-old woman comes in with some non-specific symptoms. You've got these different diagnostic tools available. Which one of them is the least useful? The one you probably shouldn't rely on here?
The answer is C, the Gram stain. And the reason is crucial. While a Gram stain is pretty good for symptomatic men, it's notoriously unreliable for women. Its sensitivity can be less than 50% because of all the other bacteria normally present. You're basically flipping a coin. That's why for women, NAATs, those highly sensitive genetic tests, are the gold standard.
All right, case number 2. A man gets diagnosed with an asymptomatic rectal infection during a routine screening. From a public health standpoint, what is your immediate priority, your first instruction for him regarding a sexual partner?
The correct action is to tell him to notify every sexual partner he's had in the last 3 months. Because the infection is asymptomatic, you have no idea when he actually got it. So that wide 3-month window is the standard protocol to make sure you're doing everything you can to find others who might be infected and break that chain of transmission.
Which really leaves us with this final, challenging thought. We are facing a pathogen that we can't develop long-term immunity against. You can be reinfected over and over. And at the exact same time, it's rapidly becoming resistant to our last effective drugs. So the question is, how do we innovate? How do we fight a pathogen that is constantly and successfully one step ahead of us?